Good morning, everyone, and welcome to today's statewide investment special virtual pop-up event on oral health integration. We'll start by spending a couple of moments providing some background information for today's event. We'll do some introductions and then launch right into our panelist discussions. Please do chat in any questions you have into the Q&A box on the right-hand corner of your screen. You can chat those questions in at any time. We do have time allocated at the end of the formal panelist discussion portion from 12 to 12:30 to respond to any questions that may not have been already addressed. So please do stick around for that additional half hour from 12 to 12:30, as I said. Before I continue on, I will take a moment to introduce myself. My name is Neetu Singh. I am the Oral Health Program Director at Healthcare for All, which is a consumer health advocacy organization based in Boston, Massachusetts. Prior to joining Healthcare for All, I practiced general dentistry in New York City for several years and eventually decided to get my master's in public health and health policy and transitioned my career from clinical practice to health policy work. And in that vein, I'd actually like to extend a personal thank you to MassHealth and Apt Associates for this opportunity and collaborating with you over the past several months to bring this convening together. It has been a pleasure, so thank you. As far as today's event, as some of you probably are already aware, the MassHealth DSRIP Statewide Investments team has been hosting a series of pop-up events for ACOs and CPs participating in the MassHealth DSRIP Initiative in an effort to provide information on promising practices and innovative strategies for member engagement. The first pop-up event was in September 2019, with the second one following up in December of the same year. Just note that the series on member engagement will continue with a third and final event at some point later this year. As far as today's event goes, as I mentioned, Healthcare for All was very excited to partner with MassHealth to bring to you today what we're calling a Spotlight pop-up event on oral health integration. The intention is to help ACOs and CPs learn more about the broad spectrum of oral health integration and to share some innovative strategies that hopefully ACOs and CPs will find valuable as you begin to think about how to integrate oral health into your respective workflows, practices, and organizations. Prior to the onset of the COVID-19 pandemic, MassHealth had planned to transition payment for the pediatric oral health quality measures, along with other quality measures, from pay for reporting to pay for performance. That transition has been delayed, but we do recognize that ACOs and CPs will still benefit from hearing about some of the various strategies and ways that organizations can take on to better support integration into various healthcare settings and community-based settings as well during this time. And just another thought there is sort of beyond ideas and food for thought on how to integrate oral health in an effort to perhaps meet the benchmarks for the oral health quality measures. Hopefully, our hope is that attendees will walk away with a deeper appreciation for the value proposition of integrating oral health into a primary care setting or a medical setting more broadly. There is strong and growing evidence to support how oral health integration can promote health outcomes, particularly for patients with chronic diseases such as diabetes and cardiovascular disease, as well as offer the potential to reduce the total cost of care for healthcare organizations, particularly through the reduced usage of hospital emergency departments for the treatment of dental emergencies. And so with that, we are very excited today to bring to you providers working in Massachusetts, as well as Dr. Christy Lumsden, who is joining us from Columbia University in New York to share their respective bodies of work on how they've integrated oral health. And just a gentle reminder, once again, if you do have questions, please feel free to submit them in the Q&A box on the right-hand corner of your screen. We have set aside time after each panel to respond to those questions, as well as the longer Q&A portion from 12 to 12:30 today. So I hope you guys are able to stick around for that. And finally, it is my pleasure to introduce Shannon Wells, who will be moderating today's session. Shannon is an independent consultant specializing in integrative public health. She is also the former director of integrated care for the Massachusetts League of Community Health Centers. In that role, she directed multiple projects focused on improving health outcomes and addressing access issues through the integration of oral health, behavioral health, and primary care at both the state and federal levels. Prior to her work at the League, her amazing work at the League, Shannon served as the project director for Boston Children's Hospital's Early Childhood Caries Initiative. So thank you so much, Shannon, and I'm going to turn it over to you.
Thanks so much, me too. I'm excited to be here today and to also introduce our dynamic set of panelists for everyone. So the first one that I'm going to introduce today, many of you may know, is Dr. Hugh Silk. Dr. Silk is a professor in the Department of Family Medicine and Community Health at the University of Massachusetts Medical School. He also teaches at the Harvard School of Dental Medicine. He is the co-founder of the award-winning national curriculum on oral health for healthcare providers known as Smiles for Life, which I know many of us have utilized. When he is not teaching and seeing patients, Dr. Silk is collaborating with HRSA and Harvard to help develop the new Center for Integration of Primary Care and Oral Health. So welcome and thank you, Dr. Silk, for being here today. Next is Dr. Matt Horan. Matt is the Executive Director of Dental Services for Harbor Health, Inc., and Dental Director for the Office of Oral Health at the Massachusetts Department of Public Health. Dr. Horan is a member of the MassHealth Dental Advisory Committee, as well as the dental faculty at Boston University and NYU Lutheran Medical Center. Our third panelist is Dr. Lisa Simon. Lisa is a physician, dentist, and researcher at the Harvard School of Dental Medicine. She has been involved in implementation of innovative medical-dental integration projects embedded in both community health centers, Harvard's dental clinic, and the hospital inpatient setting. She also practices dentistry at the Suffolk County Jail, as well as Smiles by Rosie in Somerville, Massachusetts. She is currently a resident physician in internal medicine at Brigham and Women's Hospital and Codman Square Health Center. Thank you, Dr. Simon, for being here. It sounds like you have quite the busy schedule to begin with. Finally, last but not least, coming from New York is Dr. Christy Lumsden. Christy is an associate research scientist at the Columbia University College of Dental Medicine. She serves as a research methods course lead for the Columbia Pediatric Dentistry Residency Program and is an active member of the college's Committee on Access, Equity, and Inclusion. Dr. Lumsden's work has largely focused on designing and conducting research to encourage adoption of healthy diet-related behaviors to reduce oral health disparities in young children. Thank you all so much for being here today. Next slide. Before we get started in our conversations, we wanted to take a minute to look at some of where everyone in our audience is coming from today. So as you can see, people are coming from all over the Commonwealth, which is very exciting. Looking at this slide, you can see that about 27% of the audience is coming from ACOs. Another 22% is coming from CPs, particularly behavioral health. We have another 46% that are representing other public health stakeholders, such as the Boston Public Health Commission, as well as schools of public health. And then we have 5% that are representing long-term services and support of CPs. In total, we had about 59 registered last week, and I think today we are actually up to about 81 people. So thank you all for being here. Before we get started, we wanted to take a moment to poll all of you to get a sense of where are you and your organization falling within the spectrum of oral health integration. As you can see from this slide, there's a variety of different activities related to oral health integration. You can be starting from a place of just working for a formal referral system between medical and dental and having coordinated care, to going as full up as embedded full integration, having co-located services, having back and forth between medical, dental, behavioral health. So we wanted everyone to take a moment to look at this poll. You can see this on the right-hand side of your screen, to think about where is your organization falling on the spectrum. And if you're just getting started thinking about oral health integration, that's okay as well, and you can see that as one of the answers. So we just wanted to take a few minutes to have everybody fill out their answer, and we'll take a moment to reflect on that. Okay. So it looks like we still have a few people filling out the poll, but as of right now, majority look like they're actually on the process of just starting to consider oral health integration, which is great. Because no matter where you are in this process, if you're just getting started, if you're somewhere in the middle, or if you already are perhaps a community health center or something that's a little bit more embedded, I think today you're going to find all of our panelists are going to offer you something exciting and something new to think about. So with that, we're going to get started with our first topic. We're going to turn it over to Dr. Silk. So Dr. Silk, as a physician, you have a history of kind of promoting oral health integration within primary care. One of the things we're curious to hear about from you is, could you describe your work regarding oral health integration? And in particular, how do you actually motivate and engage medical providers to think about oral health education for their patients, to think about referral processes, and what are some of the strategies and barriers you've encountered doing that?
Yeah, thanks, Shannon. Thanks for having me here today as well. So I have two slides I want to show. We're trying to keep our slides to a minimum here. So I think we'll pop one up in a second. But I think the first thing I want to say is just make the case for why this is important. Patients are in our offices. So this slide here sort of shows you that there's at least 111 million people who visit the physician's office, but not the dental office in any given year. Some people say the numbers are even larger, and you can see how large it is for especially young children, and then as people get older. So if we turn our backs on this, we really aren't doing full spectrum care. And as a family physician who does full spectrum care, I deal with behavioral health issues, the feet, et cetera. You can't just leave the mouth out. On the flip side, if you look at this slide, 27 million people are in the dentist's office and not in the physician's office. So if we don't work together, I'm missing out, especially that large group of 5 to 20-year-olds where, we could be talking about the HPV vaccine or other important preventive care. So for me, this starts with, I've got them there, I need to ask some questions, I need to take a look, and I need to have a sort of a referral process to get them across town, or, in some cases, just upstairs. If we could show my second slide, it's also about outcomes and the importance that I think part of what you said is, well, sort of how do patients respond to this? And what this slide shows is that when folks are treated, in this example, for their periodontitis versus those who aren't, and they have diabetes or stroke or heart disease or pregnant, you can see the decrease in costs annually for those patients and the decrease in hospitalizations. So if we're going to talk about the triple aim, which is better quality, better patient satisfaction, and lower costs, here it is. I think we also have to go, though, to the quadruple aim of provider satisfaction. So patients appreciate it when I ask them about their mouths. They're sort of like, wow, other physicians weren't doing that. And then they're like, well, I don't even know how to find a dentist. And so the fact that I've educated myself on that, the fact that I've made a process for warm handoffs where I can say, well, let me show you how we're going to get you to the dentist. I mean, I do that for the cardiologist. And so when I do it for the dentist, it just makes sense to people. And then we have these sort of proven statistical outcomes. So that's all well and good. But you said, what about the barriers? And so it's fine for me to say this is important. And I've got the stats in front of all of you to show that. But how are we going to do it? Everybody's really busy nowadays, even busier with COVID. And so I really think it comes down to we need to get buy-in. So we need to show them these numbers. And when I show this to physicians, they're like, oh my God, I didn't know. I want to change my practice tomorrow. Then they say, how? And this comes down to workflow. And I think as the day goes on, maybe we'll talk a bit more about that. But we figured this out for vaccines years ago. We have workflow. We have reimbursement. We have quality improvement. We do a 90% plus great job with vaccines. This is not rocket science. It's not reinventing the wheel. We just have to take what we already know. The other thing I think we have to do is we have to share ideas from across the country. Right now, Dr. Simon, who's on today, is sort of spearheading a movement that she may or may not get a chance to talk about with the Primary Care Collaborative nationally. And that's taking all these great examples across the country where we already do medical dental integration, putting them into one place so people can come and borrow those ideas and say, well, that case study looks like my office. I could take that and run with it. And so these barriers of like, I just don't know how to do it or I don't have time become, no, we're going to just work it in, and it's not all on the physician. It's a little bit on the medical assistant, a little bit on the front staff, a little bit on the nurse. And the last thing I'll say, Shannon, because I don't want to hog all the time here, is education. I mean, that's my passion. So I help run the Center for Integration of Primary Care and Oral Health, and we are really looking at how do we just get the next generation of nurse practitioners, physician assistants, midwives, family doctors, thinking oral health is part of the body from day one. So when they graduate, they just do all of this naturally. And they sort of teach up to their colleagues that are in the practice who say, really? Is that what we're doing now? So that's my hope, and I think that's where we're heading.
Thank you for that, Dr. Silk, and I think that's spot on in terms of what we're seeing these days. I'd like to give an opportunity to some of our other panelists to weigh in on what their experiences have been, specifically with oral health integration on the primary care side. And if this was a nice segue, you mentioned Dr. Simon. Lisa, I'd like to start off with you to talk about some of the work you're involved in and what your experiences have been with this.
Thanks so much, Shannon. So a little bit later in this presentation, I'll have a chance to talk in greater detail about my experiences actually integrating oral health on the inpatient side, which has some interesting analogs, I think, for some of the primary care initiatives that so many people are doing amazing things in. I basically kept a running list throughout medical school of all of the ways that even I, as a fully trained dentist, was surprised to find oral health popping up. So, for example, on the OB-GYN rotation, we had patients who were high-risk pregnancies in the hospital for weeks at a time who had a toothache and couldn't see a dentist because they were in the hospital, the irony of which I think many on the call can probably appreciate. On my anesthesiology rotation, I met anesthesiologists who didn't know what to do about the periodontally compromised teeth that patients had when they when they were about to get a surgical procedure. So I think one of the things that's most important is the awareness that Dr. Silk mentioned, and knowing that once you can make this incredibly common, incredibly prevalent problem visible to the rest of the medical community, we can start enacting really creative solutions on all sorts of fronts, not just for us as primary care providers in our office or as dental providers in our office, but also throughout the health system in truly integrated ways.
Thank you, Lisa, for that. That's great to hear all the work that you're doing, and we're going to definitely dive deeper into some of the things that you've experienced. Kind of segueing even more into this would be Dr. Matt Horan to talk about your experiences, particularly with the community health center in terms of oral health integration, particularly thinking about everyone's talking about time management, the pressures that we feel on both healthcare in general all over the place today. So curious to hear how your experiences have been in this topic of integration.
Thank you, Shannon, and good morning again. Thank you to everyone for having me come. Yeah, I mean, I can echo a lot of the things that Dr. Silk mentioned that I think are highly applicable, and I'm really excited at the poll result to see that a lot of people on the call are just starting to, formulate their concepts for what integration might look like in their work environment. One thing he kind of mentioned was enabling and forming relationships. I feel like that's super important as a barrier to overcome within different teams. The classic saying about being siloed, that's hard to break. One of the ways that you can, and that I feel like has helped improve that in the health center environment, is finding meetings that you can both attend and common topics, because then you start to develop a working relationship early on, and these collaborations and integration type activities come more naturally because they come up in your regular work. He mentioned workflows, Dr. Silk, which I think is super critical. You can't impose how you do things on the other team or vice versa. So you really need to kind of get in each other's head. And sometimes when you're starting something in terms of an integration activity, and I'll give more specific examples later, it's good to delve more into how do they usually see a patient? How does this patient usually go from person to person on the team or room to room or area to area? Because that really drives where your opportunities are for an intervention or to have the conversations with patients. The last thing is getting participation, and Dr. Silk is like an all-star of this, as we already know, but thinking about what can the medical team do, and often that is just incorporating like one or two simple questions into their already intake process that they're doing, and then how can they be involved with an intervention, which might be a fluoride varnish application or something to that nature. And then the last thing, which he also mentioned, is sharing results and best practices. I mean, it's super critical for building steam in your process. You have to somehow create a report or something to get involved in. I mean, I can tell you from the health center side as an example, we would track how many fluoride varnishes were applied versus how many fluoride varnish opportunities were there. And that's great, just to have a talking point amongst the medical and dental teams.
I think just even starting the conversations between medical and dental and behavioral health and finding ways for common ground is something that we're definitely going to touch upon with all of our panelists today of how do you actually do that? What are some of the ways you've all gone about that? I'd like to turn it over now to Dr. Lemstein to talk about her approach to this, particularly with her My Smile Buddy program, and thinking about ways that you've interacted with not just, when people think about primary care and integration, it's not just the physician, it's not just the main doctor, it can also be the team. And so curious to hear what your experience has been.
Sure, thank you, Shannon. Well, to sort of echo some of the comments that the other panelists have made already on this topic, we've had similar experiences in recognizing that you need collaborative buy-in and alignment with interests with different team members to sort of, make this happen and make this work. And one way that we've been able to do this is in finding sort of oral health advocates in the primary care side. So I work at Columbia University's College of Dental Medicine, but we are co-located with the College of Physicians and Surgeons, and we're part of the Columbia New York Presbyterian Hospital system. So we've had to find ways to link these and sort of build bridges between our disciplines. And one thing we've done is to work with physicians who are really passionate about oral health. And as Shannon mentioned earlier, much of my work is really focused on early childhood caries. So I work with pediatric patients largely. And so we found a pediatrician who's really passionate about oral health and recognizes the systemic implications and the role that the pediatric practices can play in promoting oral health and integrating care. And so we've done some work to use her team to collaborate to start applying fluoride varnish, which Dr. Horan had just been speaking about, as sort of one simple way that a pediatric practice could get involved with promoting oral health. So we've done some of that work in educating primary care physicians and providing some basic training on how to apply this and give them some suggestions for how it could be incorporated, and then let them kind of dictate what works best in their particular clinics. So that's been one way that we've had some success in integrating oral health into primary care. But the other way that Shannon had just alluded to was through some of our collaborative work with alternate providers. So rather than focus solely on integrating oral health with primary care through the primary care physicians and the staff in the office, we've been doing some work to use community health workers to sort of bridge that gap between what the providers can provide in a clinical setting and what community dwelling people really need, and providing assistance in a number of different ways. So
we'll talk about this a little bit later with some specific examples of that, but we have done some work to use community health workers to help connect the clinical side from the dentist perspective with the primary care physicians as well.
Thanks so much for that, Christy. So now in thinking about all these examples that you guys have started to discuss a little bit in terms of approaches you've taken to integration, we would be remiss if we didn't discuss the topic of the day these days, which is obviously COVID-19, particularly for any parent right now that's trying to deal with remote learning or hybrid learning or anything like that. So curious, when we're talking about some of these different approaches you've taken to integration, I want to hear from all the panelists in terms of what has the last 6 months really been like for your organizations, particularly when thinking about successes you might have been making towards oral health integration. Where does that land you today when obviously dental clinics across the country had to shut down, and then thinking about, emergency versus preventative dental care and things of that nature. So I'm going to start it off with Dr. Haran to talk about his experiences in the last 6 months and just walking us through in terms of COVID-19 and the impact this has had, particularly between this integration of medical and dental.
Sure. Thanks, Shannon. So I figured starting with a timeline would be easiest, just to kind of have some talking points to go on. So everything kind of started heating up with COVID, as most people on the call will come to mind, that early March is when the CDC first gave the guidance for known or suspected cases about needing a respirator level protection. That impacted all of our clinical planning. And at that point, it was for known potential cases. But we were already looking at reducing schedules during that first week of March and figuring out ways how to stay compliant with all the interim guidance coming from CDC. And then on March 13th is when that week of March 13th to 16th, things really started to heat up. MassHealth did thankfully release a telehealth-related bulletin that clarified. And the big thing here is that it was you could perform a telehealth activity and be paid by the MassHealth program if it was with or without live video, which was a change from what we were working with before. And it made it opened the door to the possibility of being able to have a telephone-based telehealth visit. The DEA also released guidance on telehealth that same week. And in our practice, that Sunday evening, the 15th, I believe it was, we furloughed our dental team because we were unable to keep access and keep everyone at the sites. And we converted to emergency access only. There was a period of time where we only had access via teledental. Several other community health centers over that same week reduced to either in-person, very limited emergency access, or no access, or teledental only, or some mixture of the three of those things. The Dental Society, that's the MDS acronym you see there, they released a statement basically supporting that concept of reducing to only emergency access in the interim. And then you'll see later in the timeline that was extended a few times. Then on March 17th, we had news from CMS, OCR, that HIPAA temporarily updated their guidance to allow for tele-audio with or without video. And that was for non-public facing platforms. And that basically made it so that we could use a bunch of different modalities if we wanted to have a telehealth type visit with our patients. And at that same time, we were at that point only emergency access, like I said. Sorry, yes, you can go to the next slide. So pretty much for that whole period from the second or third week of March there through June, we were in downtime mode in a variety of formats that were restricted to emergency only access. And then in our practice, we were using teledentistry to, and we still are, to pre-screen the patients that might need urgent care, both for any symptoms related to COVID, but also just escalation of how urgent is their urgent issue, and can we deal with it on the other way, or do we need the patient to come into the office, and then to set the stage for a successful visit. So telehealth has been critical for us during this whole closure period. And as we're reopening, we're still using it as a form of elimination control in terms of infection control. So also during this process, infection control-wise for dentistry, we are one of the highest risk professions, particularly our hygienists. So we've gone through a major revamping of all of our infection control protocols from a more standard precautions-based approach, if you're familiar with that terminology, to transmissions precautions level. The Mass League of Community Health Center has worked with all the community health center dental directors to really strengthen and support our team of dental directors across the state, which has been huge. And that group has been looking at everything to do with PPE and transmission-based precautions and HVACs and airflows and everything that many people, if you're clinical on this call, have been dealing with in your own practices, more than likely. And then sprinkled on top of all that have been the staffing challenges that have come with all the other issues related to COVID and people managing in their personal lives as we're trying to bring back enough staff to see patients as we've slowly reopened, which started towards the end of June for dentistry. And then since reopening, we've been rolling out schedule prioritization and also trying to figure out how we would template our operations in terms of visits and PPE and all that good stuff based on our own community risk levels for where we practice. So that's the the work and the maybe somewhat negative side of things, except for teledentistry and I think telehealth coming out of everything. Another positive thing that came out of it that I thought was worth sharing with the group is the silver diamine fluoride coverage for the MassHealth program. I don't speak on behalf of MassHealth, but I can share that this was exciting for a provider working in a community health center. It had been in discussion for a long period of time, and then during this time, it was approved by the program towards the end of June, and it's allowable twice per tooth per lifetime. So what is it? It's not a magic bullet for cavities or a dental cavity, as people say, but it can reduce or arrest decay that's already in progress. What you're seeing these pictures of, on the top one, you can see the darkening of the tooth as the special medicine is applied, and then same on the bottom from left to right. So it does darken the tooth with a permanent dark staining. There are options for dealing with this darkening afterwards, but it's exciting because it's one of the first things that we have that can reduce and arrest caries when it's used off-label in this way. And the exciting part for the system is that it can potentially reduce the amount of OR cases, especially in pediatric area. And then for someone who's like a senior, even though that's currently not part of MassHealth, but it's good to think about seniors and silver diamine fluoride. If you have any root caries or new decay under a crown, it can extend the lifespan of that tooth and also reduce the risk for a significant infection from the patient. So I would say that SDF and telehealth are the biggest positive things that have come out of the coronavirus situation so far for dentistry.
Well, it's definitely good to always look at the silver lining of things, particularly with this pandemic. And I know we mentioned to people that if you have questions, to enter them into the Q&A. We'll be going through those later throughout the presentation. But in terms of silver diamine fluoride, one of the important things to think about is also how it can help special needs patients. And there's a question that's coming up about that we'll get to. Particularly, what we're seeing is there's always been sometimes a challenge in terms of access with people being able to get special services, particularly with the special needs population. So I think this idea of silver diamine fluoride and what it can do for a variety of populations, not just pediatrics, but also special needs, the adults, I think it's really huge, and what it can do in terms of prevention and kind of this value-based care that we're trying to weave through this entire presentation today. So I think that's a great point. So thank you for that. And thank you for the timeline, because we know that looks like very stressful. So curious to hear, how has it been now with opening things back up and patients coming back in? Has it been slow? Has it been tons of calls? How is it all going?
No, I think that there's a huge backed demand, and that'll be all dental practices will be dealing with for a long period of time.
So along those lines, I'm curious to hear from some of our other panelists about the challenges and particularly maybe the opportunities that came along with COVID-19, particularly around telehealth or other inventions that you've seen. So starting with Dr. Simon again, I'd like to hear from your experiences in the different variety of settings you've been working in. How has COVID been a challenge or a blessing in disguise in some ways for you?
Thanks, Shannon, and thanks, Dr. Horan. I will say that it is an incredibly interesting time to begin working as a primary care physician. Meeting an entire panel at my community health center all through telehealth. I think for a lot of us who are clinicians really challenges our sense of ourselves as empaths and as people who can kind of build rapport, build connection. One of my first phone calls was with a patient whom I diagnosed with diabetes over the phone, which was really anathema to sort of how I viewed my ideal identity as a primary care doctor. But I think the important thing to note is that even though we have those sorts of challenges, I think for a lot of patients, the telehealth model can actually be hugely beneficial. And it may just be that we as clinicians need to grow to be more flexible and to think about all the different modalities that we have at our disposal to make care available to patients. For example, as difficult as I found it to use a phone visit, for a lot of patients, it's very easy. And as a result, we actually have lower no-show rates for our visits because it's actually much more convenient to chase someone down on their phone than it is to basically tell them, oh, you showed up late. Too bad you don't get to have your visit today. I also think that sort of from a fundamental structural level, the COVID-19 pandemic and telehealth particularly is really going to start to challenge our assumptions about what integration looks like. Co-location matters less if everyone is working from home or if patients can get a lot of their services when they're at home. So maybe when we think about what a warm handoff is, can we imagine a shared video chat, much like this one, where we get the patient, a dental provider, and a medical provider all together to kind of build that alliance and build that trust? Or, even bringing in a community health worker, as we'll talk about later, or other sort of support systems. I also think that, again, speaks to the need for systemic structures. So, for example, I'm aware of a community health center here in Boston that's actually testing all of their dental patients for COVID prior to their dental appointment, which really speaks to the need for information sharing between medical and dental teams and having a robust network in place to manage that information and support patients no matter what the result is. So I think we're going to see a lot of integration that's developed under duress, but really does pose opportunities for patients, especially, even if we as clinicians are pushed to our limits a little bit, at least at the start.
Thank you, Dr. Simon. And I think I speak on behalf of everyone here where we appreciate all the hard work that the medical community, both providers on the medical, behavioral health, dental side are being pushed through right now at this time. I can only imagine the stress that it causes. So moving on with that, I'd like to hear from Dr. Lemstein to see how your experiences, if they echo or if they're similar or different to what we're hearing from both Lisa and Matt at this time.
Mm-hmm. Yeah, I think there's a lot of similarity in how we've had to handle the COVID-19 situation and the challenges it presents. We did make a significant move toward telehealth services for dental providers in our system. And what's really interesting about that is that this had been on the table for quite some time and had been discussed at Columbia and New York Presbyterian for a while. And it was sort of planned, but it would be a rollout, and the timeline was anticipated to take years. And the initial plan was that we would roll out more integrated telehealth services for the medical providers, but down the line, integrate it into dentistry. But, COVID presented significant challenges for everyone, and suddenly it was recognized that the timeline needed to be moved up. And so the challenges posed by the pandemic really highlighted the need for these services and pushed everyone to kind of figure out solutions as quickly as possible. So what was anticipated to take a matter of years happened within a matter of weeks. And so we suddenly had the ability somehow to integrate these services through our medical system here. And we were able to provide some telehealth services on the dental side that were analogous to what we were doing on the medical side. So that was sort of the upside to all these challenges, that all of a sudden we were able to overcome these significant barriers that we thought would take many years to address, and we did it much quicker. So that was definitely a positive outcome. On the other side, though, there were additional challenges that we did not really anticipate. And some of those challenges came out of working with some of our most vulnerable populations. So some of our lowest income patients presented with a number of challenges and were not actually able to engage in telehealth services for dental in particular. And we're still trying to figure out what some of those challenges were, but some of the early issues that arose was that some patients just did not have consistent Wi-Fi. They weren't able to connect and have video services. Their cell phones didn't have data plans that would support it. And so when we thought initially this is a great service and we can provide this to everyone, now we can reach everyone in the community, it quickly became apparent from our community members that some of them just were not able to do that. And so that presented some other challenges. But I think all in all, the far-reaching implications of the COVID pandemic have highlighted the importance of integrating dentistry with primary care, that, the mouth is part of the body. I think Dr. Silk mentioned that earlier, and that's a message that we drive home with all of our dental students and our residents. And so, we try to get that out there, that it really is part of your overall health. And so I think some of the challenges that we're seeing related to COVID highlight a number of systemic issues, highlight the multitude of social and environmental factors that impact health, and really make it clear that there are a number of obstacles to receiving care that we have to come up with really creative ways to address. And sometimes these issues, just highlight the need for innovative thinking. And we'll talk about the program that we're running, the My Smile Buddy program, a little bit later, but that program was really intended to be community-based, where we're sending community health workers out into people's homes. And obviously during the pandemic, that had to come to a grinding halt. We could not send community health workers out into patients' homes. And so it started to make us think, well, what can we do to still provide the needed services and the connection to patients while recognizing the safety issues and trying to be cognizant of that. And so it just highlighted the need for different modes of communication, asynchronous communication, like text messages, having chat functions, the ability for parents to just send a message in at a time that's convenient for them, and, to communicate with our providers that way. So again, necessity is the mother of invention. So this is sort of the situation. We're faced with challenges and we need to come up with novel ways to address them.
And I think one of the things you're really highlighting is something that we have probably known for quite some time, but now we're kind of finally seeing perhaps policies and regulations go along with it, which is that there's not really a one-size-fits-all approach. And something like this, it kind of illustrates the need for having a variety of different ways and interventions to get through to our patients, particularly with the most vulnerable populations, because as you pointed out, if we can't get into the homes of patients, if we don't have the Wi-Fi capability, we have to find different ways to get to our patients. And I think that is really important. Dr. Silk, I'm curious to hear from your perspective what you've been seeing in your settings as well.
Well, again, I don't want to repeat what everyone else has said. I agree with all of those thoughts, from, decreased no-show rates to creative care. So let me take this in a little different direction. One of the things I noticed was that, as Dr. Horan said, dental offices were shut down for a period of time. In primary care, then everything starts to come into your lap. And this happened even more so because people were avoiding emergency rooms and urgent care because they were worried they were going to get COVID there. So suddenly we were getting the oral health calls, and we shared what Dr. Lumsden said, that not everyone had the best access to telemedicine. So sometimes it's a phone call. And while I really appreciated the power of the medical history, you can do a lot with just talking. It is really helpful to try to look in someone's mouth. And in some cases, we got creative with phones being able to look in someone's mouth. In some cases, we had to just make decisions over the phone. But what I realized is I live and breathe this. You know, my colleagues who don't live and breathe oral health, they were getting those same calls. And so one of the lessons coming out of this for me is we need to continue to educate medical providers about oral health, because there are times when they're going to be faced with it. The other thing, though, is I think what Dr. Simon said about this does show that you know, we're going to live in a virtual world going forward to some degree. And I'm psyched for that, because, you know, as much as we do warm handoffs, I'm a big proponent of virtual warm handoffs. And so we're going to be able to do more of that with this technology. What I noticed, though, was that being in our silos still, in the absence of a solid ACO, we still had the dentist saying, well, how am I going to get this testing done before someone comes in? When I approached the hospital to say, we should be doing the testing for the dentists and that, they were like, well, that's not what we normally do. Well, it's time to get rid of what we normally do. And so I think the ACO model will help us to think we're in this together. The hospital, like, I didn't want to do testing in my office. I don't think the dentist ideally wants to do testing in their office, because you got to put on all the PPE and test someone and then this and that. But if we would have come together and said, send them over to the tent, get that result to the dentist, get that result to the primary care doctor, now the person can come into your office because you know they don't have it, et cetera. That would have been a great coordination of care. So look, we've got hurricanes going on, we've got wildfires going on, we have COVID going on. We are going to have to be creative in our care from now on. And I think that's going to need coordinated care, so that we can do things like testing, so that we can do things like virtual handoffs, so that we can communicate better through our electronic health record, whether that's through the cloud or whether that's sharing the same system. So I think this is really, I agree with Dr. Lumsden, like, this is speeding things up, and I'm psyched for that. And so let's keep running with it and coordinate while we've got that energy.
Thanks, Dr. Silk, for sharing your perspective with us and for pointing all those interesting facts out, that it's definitely an interesting time for all of us. And I think it's an opportunity, though, for us to capitalize on more synergy between the different departments and to think about this larger and broader, particularly within an ACO context. So with that being said, kind of moving beyond this time of COVID-19, if we could possibly consider that and think of that, I'm curious to hear what have been some of the ways that you guys have found to have integration practices very successful. So I know all of you have taken different approaches, whether it be through Dr. Silk and the education platform, or whether it be through really co-located services, Miles for Life, those type of things. Wanting to hear from you in terms of what do you see in terms of being successful, and what is kind of the future, particularly in light of COVID right now, for oral health integration. So Dr. Simon, I'm going to start off with you and see what your thoughts are around this.
And I was asked to share sort of, I think, two perhaps more atypical forms of direct integration. So many of the attendees here, as well as the panelists, have done some remarkable things that I'm looking forward to hearing more about. But two of the projects I've been lucky to be involved in, I think, kind of flip on their head what's possible when it comes to integration, and so I'm excited to share them with you for that reason. So the first is this picture of a wonderful dental hygienist named Marlena Wilson, who we embedded within the general medicine unit at Mass General Hospital for about a year. And she provided both counseling and screening and bedside dental prophylaxis to patients who were in the hospital. I think that the inpatient setting can be a really wonderful place to engage with people around oral health for sort of two reasons. One is that you sort of have a captive audience, so to speak. People aren't showing up for very short appointments. They're often there for prolonged periods of time and may have sort of more availability to think about how we can wedge these services in. And then also a lot of these folks have very hard times accessing dental care in the community, either because of their multiple comorbidities, because of mobility challenges, because of actually financial challenges, which even non-hospitalized patients face. So we did a number of things to help make this successful. I think, as with all of these sorts of initiatives, the most important thing we did was emphasize team-based care. We really had a pretty exhaustive charm campaign with every tier of hospital provider, from the medical residents to the medical attendings to the bedside nurses, who are our real champions and people I'm continually grateful for. And then Marlena, I think, really showed this flexibility sort of deep in her soul that let her really roll with whatever was needed, come back if patients were having a test or a procedure. You can see that she's pushing this giant Rubbermaid cart, which is how we got her to store all of these sterilized pieces of dental equipment that we were using. And then for suction, we used the bedside suction, which is a standard piece of equipment in all hospitals. And we actually had a battery-operated, rechargeable Profi cup. So we were really able to adapt to the setting, which I think really shows what's possible. Patients loved it. And one thing that I think was perhaps the most promising to me was that it wasn't just the experience of having their teeth cleaned that was meaningful to patients, even though on average it had been about 3 years since a patient had a dental visit when we talked to them. It was that having that opportunity for the health coaching during their hospital stay actually made them slightly more likely to visit a dentist when they were discharged than if they hadn't seen Marlena. So again, thinking not just about sort of indirectly exposing and educating all of the team members within the hospital, using this opportunity to empower patients, and also really thinking about what's possible. Keeping in mind that when we think about really revamping or revolutionizing payment structures or looking at quality, I think there are all sorts of opportunities like this that will kind of come out of the woodwork. But showing that we can do this even when those things don't exist yet, and we can do it in a way that is safe and is effective and is great for patients and is actually great for providers too. The more the merrier when it comes to hospital care. And then the next program I was asked to talk about was the nurse practitioner dentist model. There are a number of attendees that I know are here today who are real luminaries in helping enact this within the Harvard Dental Center, including Dean Bruce Donoff, Jane Barrow, and Christine Reedy. So thanks to all of you and to the other colleagues who helped us with this. In this program, we integrated a nurse practitioner as well as rotating nurse practitioner students into our student teaching practice. The nurse practitioner was available to serve a number of roles to support our trainees as well as patients. Everything from providing, I would say, a curbside consult service if a patient had a particular medical comorbidity and a student wanted a little bit of backup for helping treatment plan, to things like having our dental students screen for whether or not a patient had primary care, and then being able to refer that patient to the nurse practitioner for additional referral, exam, and subsequent kind of care coordination. We were able to do this using an integrated form within our electronic dental record, which was Axiom. And you can imagine that thinking about an interoperable record where there was true information transfer between medical and dental records, there are even more opportunities for care coordination there. I think one of the most exciting things about the nurse practitioner dentist model, at least as it was enacted in our clinic, was that it provided a ton of educational opportunities. So not only were we impacting the patients who came to get care in our clinic, but also sort of hopefully generations of future patients, because we had these nurse practitioner students, these dental students working together, working through cases, actually meeting patients together, and seeing and becoming adjusted to the fact that this is sort of what care could be. And I think that really excited them. And perhaps when they go off into the real world where things might not work as well as we want it to, they might be those change agents that decide that they want something a little different.
Thanks, Lisa, for talking about these two different programs. And I think that, again, they just illustrate how innovative and dynamic models can be, and that they don't have to fit one size fit all, and that they can be very different, and thinking about ways that you can utilize them within a hospital setting or a different setting. I think these are just great models. Moving on to kind of a different perspective of that, I'm going to ask Dr. Haran to talk about some of the work he's been doing along that with community health centers, in terms of his examples and models of the different integrative approaches he's been taking.
Sure. So I'll share some of those examples of integration type activities from our health center environment. Definitely to highlight what was mentioned already, integrated EHR is probably the most powerful precursor tool or move that can be made. So if that's possible within your health system, getting the teams on the same health record is removing tons of barriers all in one giant step. And that's everything from, which prescriptions the patient's on, allergies, problems list, lab results, referrals, modules being shared. If it's a real true system of sharing, then a lot more care coordination and true integration activities are possible. So some of the ways in which we've been doing integration activities, one of them is we have a health center. We have multiple dental sites and multiple health center locations in our health center system. One of our health centers does not have any dental services. It's in a busy Boston neighborhood with no place to expand or add dental physically. So there is a pediatric medical department there, and we saw a need, obviously, to somehow have access to services within the location. So we embedded a dentist to start inside the medical department in one of the medical exam rooms on certain sessions per week with a portable chair and portable equipment. That was definitely an example of getting to know the workflows first. We had to learn things like, you can't see a child after they've gotten their vaccines because they're on one way out of the office, things like that, which you don't think of in the beginning. Convincing the team and getting them on board with the different scheduling modalities we might be using, or how to do a warm handoff between the medical team and the dental team, and who's going to take that responsibility. Another example of an integration activity, our health center operates a ESP PACE program, which, if you're not familiar with that, it's basically where the health center system assumes responsibility for the patients that are dual eligibles. So that means they're eligible for Medicaid and Medicare, and they're also usually classified, I believe the terminology is frail, based on certain medical conditions, and then they have to live in a certain zip code that you serve. And once you have those members, your health system is responsible for all their care. So that includes dentistry. So we had a need to give those patients access to dental care, and it was better for us to find a way to work with their care teams and their nurse teams to provide the care on location in their day center than have them coming back and forth from our dental sites, across the communities. And that was great because the dentists that rotate there include actually Boston University's School of Dental Medicine visiting faculty. So we have a tie-in with the faculty members there, and also in the past we've had our NYU dental residents rotate there to provide part of the coverage. So that's an example where it's basically in the medical environment, in a medical exam room, that we've embedded a mobile or portable type setup to provide care and access for those patients. Another example is in the UMass Boston. This is a previous program in the UMass Boston medical clinic. So that's the University Health Services, where the students at UMass Boston would go for their vaccines and other needs. And we embedded a dentist into that practice for a certain level of service provision, and then also to coordinate referrals with the closest health center nearby. And in another instance, we had, we have some clinics on the Cape, and there was a nearby health center that didn't have any dental services provided at their health center. So what we did is work with them to develop a referrals protocol through the Mass Highway. They used a different electronic health record, and obviously it's separate from our health system for a variety of reasons. So we worked to train their medical teams on what a referral would look like and what kind of questions they might add to their, I think they call them well checks or well exams. And when they trigger a referral, helping them figure out what level of urgency to assign to that referral, and then how to push that information through their referral system, and then their IT people working together to use the Mass Highway to digitally get that information over to our side so the patient gets contacted for appointments. So those are just some of them. I'm really excited about the mention of a nurse practitioner and the work that's been going on in Harvard. I have a dream of incorporating that into our work at the health center, and it's for the exact reasons that you mentioned. There's just endless things that a nurse could be helpful for in a dental setting. Thank you, Shannon.
Awesome. Thanks, Matt. So you mentioned a lot of the difficulties between particularly EHRs and electronic dental records, and I think I'm curious to hear from Dr. Silk and his experiences, particularly with, if you're a private practice dentist or you're, a standalone kind of clinic of some sort without co-located services, Dr. Silk, what has been some of your experiences in trying to improve oral health screenings or even, again, referrals, like Matt mentioned the Mass Highway, and trying to do referrals from one health center with dental to another that doesn't have any dental? So curious, Dr. Silk, if you can talk about some of the things that you have found successful.
Yeah, thanks, Shannon. I'm really impressed with all the things Dr. Horan said. I hope this doesn't come across the wrong way. I think we have a system that has some dysfunction to it. I think we could all agree with that. We could have better health care for all. We could have better health care that actually believes in prevention and and prevention is different than screening and that had medical and dental together. I think what we end up doing a lot of is workarounds. And that's not to say that these workarounds are not really important. So embedding a nurse practitioner in a dental office, embedding a dental hygienist in a medical office, I think they have real assets. And in some settings, it may be the only way to do this, especially if you had, like, say, a rural setting and there just isn't going to be access or what have you. At the same time, if you're asking me about EHRs, yes. I mean, I have zero communication with dentists, and so we do workarounds. I mean, we don't use the same referral system that we use for the cardiologist that we use for dental. And what that means is it's never quite going to be as strong as it could be. Let me give you another example in my world that I think relates to some of the things that Dr. Simon was saying as well. She had that amazing program in the hospital, and after a year, it may or may not have gone away. But I had a health coach in my office for a year, actually for 2 years, and it was grant funded. So we proved up and down how amazing it was. I mean, people were now out walking more, they were changing their diets, they were meditating, they were doing everything. And as soon as the grant ended, the health coach went away. Now, if we really believed in the health coach, if we really believed in the dental hygienist being in the office, if we really believed in these things, then at the end of the grant, at the end of proving that it works, it would become part of our system. And so my hope is that if we're going to go with value-based care, if we're going to go with outcomes that are true patient wellness outcomes, then all of these projects that we were working around that are workarounds would be the system. And so, again, I'm not putting down any of the work that we're doing our best. But if you have an ACO and the outcome is that the patient feels better, first and foremost, that they enjoy their life, that maybe they don't end up in the emergency room as much, that they don't end up having to have their tooth pulled, that their tooth actually stays in their mouth and gets treated, then what we would get rid of the workaround that we have to have someone temporarily in our office as opposed to we're always working together. So I think these are steps in the right direction. I think they're important steps, but I think we all have to agree that eventually we will be better off if we're doing this in a much more coordinated way. So I hope that answers your question, Shannon, that I enjoy the workarounds that I do, but I feel some sense of frustration even when it's going well. Right.
Because in a better world, if we could have a situation where we didn't have to do the workaround, it would be better for everyone. And again, thinking about workarounds, and I think one of the ways that people have been trying to work around the idea of integration is thinking about education and different approaches for getting oral health in wherever you can. And Dr. Lebstein, I know you've been doing this a little bit in Columbia, integrating nutrition along with some of the dental services. Can you speak a little bit about some of the work you've been doing regarding nutrition and oral health?
Sure. So, I think I do agree with Dr. Silk that we're doing great things, but it is frustrating when it isn't kind of adopted more system-wide. And so part of our efforts to integrate interprofessional education is to hopefully move the needle on that in the future. And so we've done a few things to kind of bring different disciplines together. And I think the benefit of integrating all of these different disciplines in the education setting is that you're sort of setting the stage early on before clinicians are out practicing and kind of set in their ways to an extent. You know, you're planting the seed that oral health is important, that it's part of general health. You mentioned nutrition, my background, I'm a registered dietitian, and so I care a lot about nutrition and what people eat, and obviously see major synergies here between the disciplines. And so, you know, we try to integrate during our students' education program these kind of connections. And so we've started to integrate nutrition into our dental school curriculum. So we have a number of opportunities in the clinic and also in didactic training to introduce our dental students to more nutrition topics, and also to work with nutrition students as well. So we do provide some education in the classroom for both dental students and residents and our nutrition program students. But we also try to find opportunities for them to collaborate on case presentations. So we'll assign case presentations to groups of students. We'll have a nutrition student, a nursing student, and a dental student work together to collaborate on addressing the overall health needs of a particular patient. And they're real patients that are coming to the clinic for visits, and they're working together to say, you know, what's going on here with this patient and how can we each contribute our piece to this puzzle to address this patient's health needs holistically. So we started to do little things like that. We're starting now to roll out nutrition counseling within our dental clinics to also provide that other piece. But the hope is that if we can do this right from the outset and get students kind of ingrained in this thinking that we shouldn't be siloed and that we all need to work together, if we're doing it at the start and trying to demonstrate it in our own clinics, they can see that this type of approach can actually work. So I'm very curious to see what happens down the line, you know, the outcome of all of these efforts. We did just at the beginning of this year integrate into a new integrated health record. So our medical providers and dental providers now use Epic. We're all in the same system. So I'm really excited about that to see where that leads, because it will streamline the referral process and allow our medical providers to see the notes from the dental visit and converse as well. So, you know, we'll see where that leads, but hopefully these efforts will eventually, you know, move things forward and making kind of system level changes so that it's not kind of a one-off or temporary connection with another provider.
Thanks, Christy, for sharing that with us. It sounds like some really, again, interesting models and different ways of thinking about integration as a whole. One of the next topics, and I'm going to keep asking you and put you on the spot a little bit more here, is one of the things that we're thinking about with integration is we've talked a lot so far about the medical community and what they can do in terms of oral health integration, but again, thinking about what is the role of other paraprofessional healthcare workers. So thinking about medical assistants, community health workers, perhaps even social workers. There's been a lot of conversations about navigators and patient navigators, patient coordinators, all of those different types of roles, and what part could they possibly play in terms of oral health integration and expanding access or expanding the ability to reach our patients. So curious to hear about your program, the My Smile Buddy program, and how that has really incorporated different levels of providers and how that has been successful or challenging in your perspective.
Sure. So you mentioned a number of different types of providers, and you know, one type of provider that we've started to integrate in our clinics is a social worker. So we do now have social workers who work in the clinics, get direct referrals and handoffs from our clinicians, including our residents and our students when they're seeing patients. So that's helped tremendously in addressing some of the other needs of our patient population. But there's still kind of a challenge there in working with patients in a clinical setting versus kind of meeting people where they are and getting out in the community. And so we have been working for a number of years now on this program called My Smile Buddy, and I know you have a screenshot up here of the program. But the idea of this particular program is that it connects community dwelling patients with community health workers. And the community health worker model is not new. Community health workers have been around for a long time, but using them to provide oral health education and linkages to oral health services is somewhat new. And so we recognize the value in linking families with community health workers as another way that we could connect with patients, particularly those in greatest need of health services. And we chose community health workers for a number of reasons, but one is because, you know, they remove the barrier of sort of the white coat syndrome. You know, when patients come in and they see a clinician or even, you know, a social worker or a dietitian in a clinical setting, it's difficult to really connect on the same level as they would if they were out in the community and talking with someone. So a community health worker is a peer in the community, often with a similar background to the patient population they're serving, and they are lay health workers. So they do receive some training in general health, and in our case in oral health, but not so much training that they then become another level of provider. They're still kind of maintaining their peer status, and that allows them to really connect and establish rapport with families on a completely different level than we could in a clinical setting. So the My Smile Buddy program uses community health workers to connect with families to address the main behavioral drivers of disease. In our case, we're focusing on early childhood caries. So we're talking about daily diet and oral hygiene behaviors. And recognizing that a lot of our kids who are hardest hit by this disease are the ones who are just challenged by a number of social and environmental challenges in their home lives. And so we had to come up with a way to kind of address some of those barriers to engaging in these oral health behaviors that extended beyond just the clinical office. So we essentially equip community health workers with an iPad, and you see a little screenshot there on the right of the iPad app. And the app is designed to facilitate counseling between a community health worker and a family. And so, you know, as I mentioned, we didn't want to overtrain the community health workers to turn them into oral health professionals. We wanted them to still maintain their status as peers. But at the same time, we wanted to ensure that they had science-based recommendations and information in order to provide appropriate education and guidance to families. So the app really serves to provide some education and training. There's a risk assessment module to a few questions that are embedded in the app. It comes out with an individualized risk score and helps the community health worker establish a specific goal that's relevant for that particular family, and then come up with an action plan and kind of wraparound support so they can follow up with that family. So it's just another tool in their toolbox to address oral health and to provide, you know, guided counseling for families. The benefits for us in working with families and working with community health workers was that we were able to address a lot of the barriers that families are facing that we in the office setting just are not able to recognize and address directly. And, you know, community health workers are embedded in community-based organizations. So they provided linkages to social services that families needed that we didn't have access to in the office. And because they were working in community settings, in patients' homes, they learned a lot about the challenges families were facing, from difficult living situations, living in one room in a shared apartment, for example, where they don't have access to a kitchen or a bathroom that's solely theirs. It's shared with other tenants in that apartment, to challenges regarding legal issues and immigration status that were serving as barriers to providing care or to receiving care. We had a number of families who canceled appointments for their children because the parents were undocumented and were afraid to come in. So these are just some examples, you know, transportation barriers, language barriers, et cetera. So the community health worker model removed some of those challenges because they were able to go into the homes, become close allies with families and partners with them, and establish rapport. And you see on the screen now a picture of one of our great community health workers, Jade. She was in with a family who agreed to be photographed. And, you know, they connected families with a number of services. And in terms of providing oral health care services, they served as navigators. Some patients just felt more comfortable if they had their community health worker with them during a visit or helped them make appointments. Sometimes language barriers were a concern, but also the challenge of not feeling empowered to speak up and ask questions during visits, not knowing what they should ask. Things like that. So it just became another way that we could extend the reach of our clinical services and connect families with the services that they need to overcome some of those basic barriers to engaging in optimal health behaviors. So yeah, that's kind of a brief overview of our community health worker model.
No, Christy, that's great. Thank you for sharing that model with us. And I think that hopefully is kind of planting the seed for a lot of our audience today to think about, again, how can you utilize different professionals in the community, whether it be community health workers, the navigators, medical assistants. And I think we can address this a little bit more as we get into the Q&A as well. I want to take a moment to thank our panelists for sharing some of these models. Elise, if you could go to the next slide, I think we want to take a moment here to reflect back on the beginning of this session. We talked to everyone about where are you on the spectrum of oral health integration with your organization, and many of you felt like you were kind of just in the beginning stages of thinking about it. So after hearing about some of these models that we mentioned, some of them being referral processes, some of them being, you know, telehealth, shared clinic, where on the spectrum would you like your organization to be in the future? And again, you can kind of see those answers on the right-hand side and give you guys all a moment to think about where you want to go and what, after hearing from our panelists, do you think is feasible or perhaps sustainable for you? Okay, so looking at the results of the poll, we have a little bit, we have a couple that are still not sure, which is completely fine. There's a lot of information today. A few mentioned having formal referral processes in place. Definitely, I think the majority are saying opting for full integration. So again, thinking about dental providers are part of the care delivery team with shared finance and accountability. So I think that's great. So thank you everyone for that. So now, thinking about the poll question that we just did, we wanted to take we reserved 10 minutes for questions within this hour. Our panelists have also graciously agreed to stay on the line for additional 30 minutes until 12:30 to keep answering questions. So you can keep adding your Q&A, your questions in the Q&A chat box. So we wanted to take a moment to think about anything that you guys might have that you want to ask the panelists, anything in particular regarding any of their models that they talked about, as well as we also wanted to draw your attention to the different resources you can find on the MassHealth DSRIP TA website. So a lot of you have already been asking some of these questions related to, you know, we talked about telehealth. You can find telehealth billing codes on this website. You can find the dental provider registry. Oftentimes people say, where can I find a dentist that takes MassHealth? These are the places where you can go to. We mentioned today a lot of educational resources for training medical providers on oral health, the Smiles for Life curriculum, Healthcare for All, oral health integration case studies are there, as well as the different policy briefs on oral health in Mass ACOs. So wanted to make sure that all of you were aware of that information. So at this time, I think we're going to take a small break to field some questions from the Q&A box. So one of the first questions we have is actually a major concern that medical providers have is understanding a patient's dental insurance benefits. What suggestions do you or any of you on the panel have for helping patients understand their dental benefits?
Shannon, I could take that one if someone hasn't volunteered yet.
Awesome. Thank you, Dr. Simon.
I love being in Massachusetts and being able to tell all of my medical colleagues the wonderful news that MassHealth provides such a robust spectrum of dental benefits. I feel like it is very rarely not the answer that physicians or other clinicians expect, and it is deeply empowering because I think a lot of the expectations that I've noticed in many of my primary care colleagues is that why should I bother doing this or screening for this if I can't use it to help my patients? It doesn't tell me anything that I don't already know. And so being able to share with them that, oh, actually, there's this amazing spectrum of services, and here are some tools you can use, including the MassHealth Dental search engine and the Mass League FQHC search engine, can be really exciting. And then you're also kind of seeding these ambassadors of dental coverage news who will be able to then counsel their patients who might also mistakenly believe they don't have dental coverage within the primary care setting, so that when a physician asks, do you have a dental provider? And the patient says, I don't think I have dental insurance coverage, they can learn in that moment that they do. So I do think that this is an instance where education and then also using sort of technology to share this news with folks can be really helpful.
I'll just add to that really quickly. I think Dr. Simon's right on. It is amazing how many physicians don't know that. And I think some of it is because things have changed over time, what was covered, what wasn't covered, and people are a couple of years behind and lagging. So I think Dr. Simon's right. We need to be a little more nimble about sharing that information, whether that's, I know we have an oral health committee at the Mass Medical Society. We try to put, information like that out to our members, but if insurers and MassHealth and others were sort of like keeping that messaging coming to providers so that they can give the correct information to patients. I think, MassHealth does a really nice job of having 1-800 numbers and a website where people can go onto there to get more information. And so I am constantly reminding people that, you can take the power into your own hands and give a call to MassHealth, and that will help you to find a provider in your area that takes MassHealth. And not everyone has maybe the technology to go to the website, but the 1-800 number is quite easy. And so I do find a lot of patients doing that and getting good information that way.
From the health center side, or if you happen to be lucky enough to be in a care environment where the patient may be completing the referral as part of their checkout from medical to go to dental, or from medical to dental to go to medical, vice versa. Those staff members are key to have understand some of those basic questions, because that's the level where the patient might come up with the question about, is it covered? Can I go to the dentist here? And if they're trained on the basic knowledge of that, it helps a lot.
Matt, that is absolutely, I 100% agree with you. Having ran a bunch of different integration projects throughout the years, I think one of the biggest misconceptions is that having the front desk staff people and actually know the benefits and letting them know that, yes, majority, particularly in our state, majority of things are covered is huge, because we know that, dental can be very expensive. And I think people rightly so have a lot of concerns about, will this be covered? Will this be out of pocket? How much is this going to cost? And so I think utilizing this as a team approach is huge. Another question that we got in that I want to pose to the panel is thinking about, how do I engage patients in their oral health care, particularly for patients with really complex care needs? Going to the dentist might not be on their number one list of priorities. And I think oftentimes people think of, well, if I'm not in pain, if my tooth isn't hurting right this moment, then I don't need dental care. And particularly in thinking about COVID-19 and people being somewhat maybe avoidant or nervous of things, what advice do you have to our audience in terms of how do you motivate patients, or how do you remind them that this is in fact should be a priority?
I can start with that one, because it comes up a lot. So again, I think this comes back to education. I think medical providers and paraprofessionals need to understand the importance of oral health and its effect on the rest of the body. In the acute situation, you said, that can get like really bad, really quick, close down the airway, brain infections, people die. A lot of people die every year in the US from this. But, we also need to focus on the effect that this is having on their heart disease, on their diabetes, on their rheumatoid arthritis, et cetera. And so, again, education is key. I'll put in a plug for the Center for Integration of Primary Care and Oral Health. We're starting a 100 million mouths campaign where we want to try and educate every medical provider, health school in this country, again, midwifery school, family medicine residency, et cetera, so that every person graduating gets this message, understands it, and really wants to engage patients around it. So we want to do this state by state. And I think what was said earlier about, community health workers, the Smiles for Life modules, there's a module for community health workers. I think if we could have every community health worker understand this, so when the person's at home and their only contact with the system is the community health worker, they're getting that same consistent message. This is important. Let me tell you why. And these are not workarounds. These are people who are in the system, who will always be in the system, and will be able to do that. I think one of the things we do in medicine, I think is done in dentistry as well, is motivational interviewing. So you have to listen to your patient, and what is it that's going to get them to go to the dentist? So if it's, I'm worried that I'm going to get sicker, and if I get sicker, I can't babysit my grandchildren, which I have to do right now during COVID because my daughter has to work. Good. Let's get you to the dentist for your grandchild and for your daughter. Like, listen to the patient. What is it that motivates them to change? Go with that. Not, do you realize that such and such is going to happen? I can be paternalistic with my kids, but, it doesn't work with the rest of the world. So you have to understand it in the first place. Everybody has to understand it. We have to have consistent messages, and we have to sort of listen to people and use motivational interviewing.
One thing I just want to highlight is that I think this really speaks to the importance of engaging primary care clinicians in this kind of work. I think one of the things that is most meaningful and most beautiful about primary care is the ability to ally with a patient over time in ways that are really different than a lot of other places in the healthcare system. When I was a medical student, I was on a primary care rotation, and I actually had a patient who, even though she knew I was a dentist, wouldn't let me look in her mouth because she was so ashamed of how poor her dentition was. And that's not someone where the goal of our first meeting is to get her a dental referral. But what is so special about being that person's primary care provider is that we can figure out why, okay, this is not something that's going to happen now, but together we're going to build that trust. We're going to understand what her other needs are and sort of the barriers, whether those are psychological or whether they're material, and work together over time. And I think, obviously, dental clinicians can have beautiful longitudinal relationships with patients, but for a lot of patients who really struggle to get into the dental chair, those relationships that we can leverage are in the primary care setting. So it's both about education, but it's also about alliance and about patience. It's about knowing, you know what, we may not achieve this right now, but I know I'm going to see you again in 6 weeks, and we're going to revisit it. And all I can do is continue to share the information and knowledge I have and work to empower you and get to a state of readiness, whatever that looks like for you. And I feel like primary care is like the perfect jewel in the crown of being able to do that for our patients. And that's where we can get those oral health victories.
Thanks, Lisa. I think that's incredibly spot on and a great way to think about, we want to be cognizant of time right now. So being at 12:06, we want to take a moment. We actually are going to stay on with all of our panelists to address some more questions that have come in. So if you have the time, we'd love you to stick around and type in your questions into the Q&A and be able to talk more one-on-one with all the panelists. But at the same time, we want to take a moment to thank all of you, all of the providers on our panelists. This has been incredibly insightful and helpful, and just wanted to thank you for your time on this busy day. Wanted to let everyone know in the audience that this is being recorded and that the link will be sent out. And so again, this will be found on the DSRIP TA Marketplace, along with all the resources that we mentioned within a few days, as well as the full question and answers that's going to come through on the Q&A section. So just wanted to take that moment to thank all of our speakers again. and to officially kind of close this out. But at the same time, we have a few more questions coming in. So for those of you who want to stay and listen to the questions, you are welcome to. For those of you who need to close off, we totally understand that as well. So thinking about what we were just talking about in terms of integration, one of the things we wanted to do would be talking about how have, all of you guys kind of mentioned some of these different providers that are coming in, whether it be the nurse practitioner that's embedded in a setting, a medical assistant, community health workers. One of the questions that came through on the chat box is there any particular licensing issues coming through with that? So Dr. Simon, I don't know if you want to talk about this first, or Dr. Limstein, you chiming in, but what has been your experiences in terms of using and utilizing some of these different modalities?
I'll just mention, and often I think this is something that a lot of primary care clinicians aren't aware of, that there are a broad spectrum of oral health services that are considered within the scope of practice of NPs, PAs, and physicians specifically, including things like dental anesthesia. In fact, the only thing that a dental license is sort of distinctive in terms of allowing is restoration of teeth. So even extracting teeth, not that I'm encouraging untrained people to be doing this, extracting teeth is considered within the scope of practice of NPs, PAs, and physicians. So it's all about training and confidence and self-knowledge rather than specific practice acts that are keeping people from doing these sorts of interprofessional activities.
I think in terms of licensing, everyone can provide education and everyone can employ motivational interviewing, as Dr. Silk mentioned before, which is something we're huge advocates of. And certainly everyone can make referrals. And I do get a lot of questions from clinicians about making a referral to a community health worker or to a social worker or a dietitian, because there's a lot of just confusion about what their practice covers, what their scope of work is, and how you can actually make those referrals and what's covered under insurance. But my suggestion is always, reach out to those providers in your community, reach out to your network. You would make a referral for any other kind of service. This is sort of the same thing. And if you're unsure about what's covered and what's not covered, generally those providers have a really good grasp on what is covered within their particular scope of practice.
Shannon, I'll just add quickly that, practice acts and these types of things, and I think it just leads into, what we can bill for and what we can code and all this. They're all restrictive. They're all ways to keep the system stuck. And I don't think anyone wants to keep the system stuck. But we use words like, well, it wouldn't be safe for someone to do something. I've heard that for many years. It's not safe for a family doctor to deliver a baby. Only obstetricians can do that. Well, there are, thousands and thousands of family doctors that deliver babies because they do that extra training and they get good at it. There are physician assistants that can put a cast on an arm way better than I can do because they spend all their time putting casts on arms. So I think, again, if you looked at this as a universal system, so again, I grew up in Canada, it was a universal system. You want good outcomes because the whole system is losing money. The whole system is losing health when you don't have that. So if you're an ACO and you say, I need to blow up practice acts, I need to blow up all these things to say, what is best for the patient? Now, I am not advocating, just like Dr. Simon is not advocating, that a physician should go and start extracting teeth. That would be a waste of that person's time to do one a year. But if we coordinated this and said, who is the best person? How do we move people around back and forth and all that? And it may be that just like it's not all that much, an obstetrician shouldn't spend their time doing a really easy birth. Midwives and family doctors can do that. We're not utilizing them properly. So we're not utilizing the dentist properly if they're painting varnish on teeth. They got way more skill in that. So let's get the school nurse painting varnish on teeth. Let's teach healthcare workers how to do that. Community healthcare workers. I mean, it's trainable. let's think globally, let's think ACO-like, let's think outcome-like, and then we don't have to get caught up in practice acts. I mean, you know, obviously there's still laws. We need to work them through, but we can do better. We're more creative than that.
I wholeheartedly agree, Dr. Silk. Curious if anyone else wants to echo or chime in on this.
Sure, Shannon. I'll make a couple of comments on that. No, it's very exciting to hear the passionate responses that we just got. And I think it kind of, to go back to what Dr. Silk said a while ago about workarounds, and I agree with his comments that he made generally. I feel like the workarounds, including like the integration examples that I gave, they are very important, because even though they're not going to be the most effective way to get the same outcome that you want for your health system, they teach you what you need to know in order to carefully blow up the system and carefully plan. For example, you know, I mentioned we had a provider at that time, a dentist embedded on certain days within the pediatric medical site that didn't have a dentist. Well, of course, if you take a more macro view, there's more efficient ways to do that if all barriers are removed. One thing, like he just said, you don't want a dentist being the one to paint, quote unquote, paint teeth with varnish. That's true, because their time could be spent doing different activities higher in their license. So I think the secret becomes thinking about, okay, well, who could take that part of the task on to get the same health outcome or better? And in that case, it might be the medical assistants who in our state can, if they have a training completed, they can apply fluoride varnish. And I think in my mind, the secret for what can people do under the license outside of, you know, learning and contacting their board of registration and understanding the malpractice coverage is thinking, can I do this safely? Can I deal with any negative health outcome that could possibly come, of which fluoride varnish is super safe and easy to apply? So yes, the medical assistant could deal with that. And then, you know, can they provide the care at the same level of a specialist in that area, which there isn't such a thing as a fluoride varnish specialist. So I think you're good to go in that kind of questioning. But I try to think of things that way when I'm thinking of what can this team member provide within reason, those little steps to go through. You mentioned other provider team members. We've had other people involved with referring patients within the practice. So we've used a dental care coordinator in the past, which was like a custom kind of care team position that we made. But really, it could be any member of like a referrals team on a larger health system. And that person was going into the patient records or working off of a report that was telling them patients that could have a sealant applied or might be eligible for it. For people on the call who don't know what that is, it's a protective coating that goes on over the tooth to help prevent it from getting a cavity. And this person would go in, identify those patients, and then do the additional steps to ensure that they were getting a scheduled appointment, and then making the alterations in the chart that the provider and the dental assistant team would get an alert that tells them that's why the patient's here today. Make sure we get that sealant done as soon as we can. It's one of the few evidence-based things that we know is effective in our field. So that's another example.
Shannon, this is Neetu. I'm just going to jump in real quick, if that's okay. Just thank you to everybody for being here. Just a couple of thoughts. I think in terms of building trust between patients and providers, it's important, I think, to also be considerate of cultural humility and maybe considering people on your staff who are of the same color and background as the patients, because not all of us kind of have the same background. And so just in terms of the educational piece, sometimes it's just really valuable to maybe have your front desk person come in to have an appointment with you and provide that education to the patient and have it just resonate in a different way. I found that really helpful in my own clinical experience eons ago, and so I just wanted to put that plug in there. But this was a question that sort of I've been mulling over a little bit in terms of and building on the scope question for all of you. When thinking about including either a dental provider within a medical setting or a nurse practitioner within a dental setting, have any of you sort of encountered supervision issues in terms of oversight and having a provider working in a setting that's not necessarily of their training.
Me too. I was just going to say we're trying to get a project like that off the ground in Barre, Massachusetts, at the health center there with a dental hygienist and the dental hygiene school. And yeah, we're running into all sorts of sort of internal sort of issues, lawyers getting involved as to who's going to oversee things. And you know, even though there's a model for this to happen in other places right now with the dental hygiene school and dental hygienists, and you know, not always having a dentist on site, but a dentist overseeing things, but is that okay or not? And again, the hygienists aren't going to be, you know, doing anything beyond what they normally do. But yes, there are lots of people who, in my mind, you know, overinterpret things. And again, safety is really important. I mean, I haven't been sued to date, and I don't plan on being sued. I try to practice very carefully. But I do think if we overinterpret things, then we hold back progress. So yes, I think this is going to continue to come up, which is why, again, if we're going to be thoughtful, I mean, I have friends who are Amish, and when the Amish want to make a decision, they sit down as a community, they say what is best for our community to move forward, and then they move forward as a community. So we need to think about this as a state. You know, what do we think is best? Do we think it's okay to have a dental hygienist in a medical setting with a dentist not literally on site but is overseeing the care? Then let's decide that, and then we don't, you know, decide this one by one. That would be my, you know, thought.
Like, I can briefly just mention with some full disclosure and honesty that we were able to fudge the oversight rules a little bit for our dental hygienists because we were doing it as part of a clinical trial, and also because it was in a hospital. Maybe this is just a good endorsement for hospital-based oral health care. In a facility that actually did have a dental clinic, we could say that there was a dentist on site, although I would argue that the level of a remote responsibility was probably perhaps higher than that definition typically entails, because the dental clinic was like all the way across at the other end of the institution. And I will note that, you know, states that have more expanded dental hygiene practice acts and also using roles like the public health dental hygienist here in Massachusetts are sort of ways to embrace the limitations of what is possible right now. But I also think, again, we can be thinking about what should be rather than what is.
Thanks, Dr. Simon, for jumping in with that. And I think that's the kind of beauty of clinical trials, is how they can let you get some of that grace in there. We have a few more questions before we close, but I think one of the things we want to make sure everyone's walking away with today is that, again, thinking that the audience is people coming from ACOs as well as CPs, community partners. I'd like to probably turn this over right now back to Neetu at Healthcare for All, and then to all of you as a panelist, just to think about, again, what would you say would be the 2 to 3 examples, kind of low-hanging fruit to think about from an ACO perspective of oral health integration, of where can they start, where can they begin, that you would like to give them. So Neetu, I'm going to start off with you to think about that, to provide and possibly resources, and then open it up to the rest of the panel.
Sure. Thank you for that, Shannon. I think the first thing that comes to mind is actually the MassHealth Dental Provider Directory. I think having that referral base in place for the ACOs to kind of be in touch with and start to build on and to know where the community-based dental providers is really important, just from the feedback and interaction I've had with ACOs and CPs over the past several years. I think that seems to be one of the key challenges, in that they're aware of the oral health quality measures and kind of need to figure out who it is that they can send their patients to and develop that relationship with, and have it eventually be bidirectional. But that initial step to creating that referral base is really important, and the resource is available and up on, it'll be coming up on the slide, but it's also it'll be on the main webpage as well for people to go ahead and start there. I think the other thing to consider is just asking a very simple question of, do you have a dentist? Do you have pain in your mouth? When was the last time you saw a dentist? Like, very simple non-invasive questions that primary care providers, some are really great at asking and others maybe not so much. I mean, they have a full workload, of course, but just really thinking about very simple questions to put into their intake assessment forms and just have that sort of plant the seed within the patient that their mouth is important and is also being considered by the provider. And then I think the last thing I'll just comment on is building on what others have said around the fluoride varnish piece. That is currently a covered benefit for both medical and dental providers in Massachusetts. It's there, it's great, and the Smiles for Life curriculum and other sort of MassHealth programs are readily available to provide that education for providers to deliver those services.
Thanks, Neetu. I think those are all fantastic resources, and I want to open it up just one last time to our panelists to chime in with any other examples or things that you think are great takeaways for our audience before we wrap up with additional resources and closing.
Sure. I can add basically definitely supporting what Neetu said, but also kind of circling back to the original comments I made where forming relationships is probably your most valuable step, whether that be between one care team and another or your patients and your care teams, to drive the demand for that level of response from your system, meaning that you're referring back and forth. That's a good level to start at. The questions that Neetu mentioned, whether it be one or two questions in the primary care provider's workflows, and then getting that to result in a referral is a huge first step. Agree as a group on what you can measure and find something that's easily measurable right from the beginning that you can track over time to see how your change is going. And if a referral level of change is going well, consider adding an intervention like a fluoride varnish. Not only does MassHealth cover it in both settings, but they also, in the dental program, do have an outreach team that can help with training and resources and other billing guidance. So, I mean, it's all at your fingertips. And the last thing is, my summary things would be to think of the macro level change that we're going through and the fact that how great is it that we're even having this call today? The system is starting to change in some ways. There's a new waiver being applied for. People are thinking of the system overall and the health outcomes that Dr. Silk mentioned. So I think it's a very exciting and positive time for our state and our patients and all of us that are living here in the health system.
You guys have taken all the easy ones, all the good ones. So there's not much left to say, except I do think with all of those wonderful, wonderful ideas, we just have to think about how do we motivate providers, how do we incentivize them. Fluoride varnish is easy because there's a reimbursement. It's more tricky when you're talking about an adult and, you want to do an oral cancer screen or you want to motivate them around their periodontitis and diabetes. And so how do we get providers to do that? And I think, there are other incentives in the world, quality improvement projects. Part of our, board recertifying for our board and our licensing and CME and all that, we are meant to do quality improvement projects. So sometimes that can be an incentive for a provider to want to do something. When you, as Matt said, when you record this stuff and you show people graphs of the progress you've made as a team, people get excited about that. Hey, we're doing better care. So even if you're not going to get reimbursed, but you're now making better referrals and patients are happier and you're recording patient satisfaction and things, that will motivate people. We take a Hippocratic oath and other oaths for a reason. And so I would think about the other incentives.
Just to kind of build upon what Dr. Silk just mentioned, being able to share data with people really makes a big difference, especially on the provider front. And if you can share that patients want this, that this is something they're looking for, that this is a benefit that they feel is valuable, then I think that can certainly serve as a huge motivator for clinicians to find a way to integrate this, more fully into their model. And for us, just sharing some stories from the field and sharing with physicians that community health workers told us from their community-based organizations, from focus groups and other assessments that patients were looking for this, that they didn't know where to start, that they wanted this information. that was really helpful in kind of piquing their interest, I think, in saying, you know, this is obviously a need, and perhaps as the primary care provider, I can help to fill that need. So I think, you know, just again, information sharing is huge. And then to swing back to what Neetu mentioned just a few minutes back, you know, we need to think about cultural implications here in everything we do. And, you know, going back to think about the community that you're serving and trying to identify individuals that can speak to them and speak to their needs and communicate more fully with them makes a huge difference.
Thank you for that. And I think that is a wonderful last statement to kind of end today's conversation on. And I thank everyone again for participating, and for our panelists. I think this has given everyone a lot of food for thought. And like Matt said, I hope that this is the beginning of many discussions and conversations and of systems kind of changing in this direction. Once again, we just want to end this by putting up the final slide that should take you to the MassHealth DSRIP website for additional resources. Again, in a few days, there will be a recording of this presentation as well as all of the Q&A. So just want to give a minute to get that. So again, for a lot of the things that we were talking about in terms of resources, where you can go, healthcare for all, the telehealth, Smiles for Life, different resources, where to find your dental providers, all of that is going to be here on this website. So we encourage all of you to take a look at that.